morning. I'm Dr. Fahad Merchant, and I'm a practicing diabetologist in Mumbai Central. I'm going to speak about the ARB usage in COVID-19. So, today, the 2019 novel coronavirus outbreak is being a major concern of the scientific community to treat with potential medications. Following a rapid increase in the cases of COVID-19, different observational studies are undertaken to identify the possible risk factors for infection and related poor outcomes. So, 17% diabetic cases were reported among 52 critically ill patients with COVID-19 and 16.2% diabetes and 23.7% hypertension cases were identified from 1099 patient by Guan et al. Similarly, out of 140 hospitalized patients, 12% diabetes cases and 30% blood pressure cases were observed in critically ill patients with COVID-19. So hypertension was independently associated with severity of COVID on admissions, and hypertension is a risk factor for aggravation of disease in COVID-19 patients. The large percentage of patients with hypertension undertaking ACE inhibitors or ARBs was a remarkable characteristic among those presenting with severe COVID manifestations. These are classes of antihypertensive massively used as first-line therapy due to the additional kidney and cardiological protection that occurs regardless of the use for blood pressure control. ACE2 is established as a functional receptor for the entry of SARS-CoV-2 S into the cells, and SARS-CoV-2 enters the host epithelial cells after its spike protein receptor binding domain to the membrane found in ACE2, that is the angiotensin converting enzyme 2 receptor. ACE2 is a type 1 integral membrane glycoprotein. The highest expression of ACE2 is observed in the kidney, the endothelium, lungs, and in the heart. The probable rationale proposed for the possible relation between the use of ACE and ARBs and progression of ARDS in COVID patients is the increased availability of ACE2 attached to the surface in the lung endothelium and inherent effect of these two classes, leading to an enhanced coupling of SARS-CoV-2 to ACE2 and its consequently cell entry. So receptor binding domain of the SARS-CoV-2 has a stronger interaction with ACE2, and any increase in ACE2 expressions may potentially amplify the virus capacity to enter the cells. Distinctly, ARBs increase angiotensin 2 availability since this class blocks its coupling with AT2 receptor, leading to compensatory upregulation in the membrane. Cellular entry is followed by endocytosis and further viral replication and subsequent release. SARS-CoV-2 after entry inside the cell causes downregulation of further ACE2 expression. ACE2 is more responsible for conversion of angiotensin 2 to 1 to inactive angiotensin 1 to 9. ARB oppose ANG2 actions by blocking endocytosis and receptors and may also cause overexpression of soluble form of this ACE2, which intercepts with the binding of SARS-CoV-2 with membrane bound and ACE2, thus inhibiting the viral entry into the host cell. The new data published in the JAMA Network Open shows that adjusting for multiple variables, COVID-19 patients treated with ACE inhibitors and ARBs had significant lower risk of death and severe adverse events, which include the need for intubation, mechanical ventilation, or admission into the intensive care unit when compared with those not receiving RAS inhibitors. BRACE Corona trial, again, which was the trial was presented in the ESC Congress, showed that hospitalized patients with COVID-19 who continued on their previously prescribed ACE inhibitors and ARB were not at risk of dying or remaining in hospital when compared to patients which stopped the medicine. The Replace COVID trial, which was published, came to the similar conclusion. So average discontinuation of this therapy put them at risk for complications, rebound, exacerbations of the disease. And in patients with hypertension, discontinuation, switching of a drug can lead to a rebound hypertension and transient suboptimal control, which can augment the risk of developing cardiovascular events. Similarly, in the heart failure patients, sudden discontinuation of ACE inhibitors has shown to result in deterioration of clinical status, which is possible relative increase in mortality. In post-myocardial infarction, patient with LVD, RAS blockade provides a mortality benefit. Similarly, the use of ACE-ARB reduces the risk of diabetic complications in patients with diabetes. Until more data becomes available, we feel that continuation of these drugs may or may not increase susceptibility to SARS-CoV-2, but sudden discontinuation of ACE and ARBs is more likely in decompensation of previously stable clinical state. Therefore, based on all this data, the European Society of Cardiology and American College of Cardiology does not recommend the discontinuation of ACE inhibitors or ARB therapies in patients with heart failure, hypertension, or myocardial infarction who are also suffering from SARS-CoV-2 infection. Moreover, ACE2, whose expression is enhanced with the ACE inhibitors or ARB, has the ability to suppress inflammation and has been suggested as a potential new therapy for inflammatory lung disease, cancer, diabetes, and hypertension. Given the fact that no current evidence that proves a direct cause relationship between the use of ACE and ARBs and COVID-19 infectivity or mortality, and the facts that ACE and ARBs have benefit in cardiovascular disease. Thank you very much for listening.